Thanks, Dr. Pardon. Thank you. Good afternoon. My name is Johnson. I'm one of the academic FY2. And the reason why I insisted to present before Margaret is because I think my presentation will give you a good overview of my experience and perhaps a little bit of surprise, and as well as some of the pitfalls I had throughout my academic foundation years that perhaps will give you a good message for the young academics or for senior academics who want to give advice to young enthusiastic academic clinicians to be like myself. So I've given it a really canny name, Pluripotency of the East of Scotland Academic Foundation Program, and I think it's a prospective outcome study because we're still doing it just now. And so how did it all started? I am really an ophthalmology geek. I went to Harvard for my research elective as a student assistantship, and I have established a good ocular biometric database in Edinburgh that I thought, perhaps this is the field that I want to really go in and look at biometrics and apply a lot of physics into my research. And then Bradford Shingerton, who's a professor, is really someone who has a lot of knowledge on a condition called pseudoexfoliation. And interestingly, it is a systemic condition where there is a lot of protein being produced and it gets deposited to structures around, and in particular around the zonules, thus making a lot of the Caucasians having complications for cataract surgery. And I thought this is fascinating because I've never seen it before when I was young, and I really loved it. And I actually wrote in to present on my research on pseudoexfoliation to the grand rounds, but it got turned down. So, and I also got really interested into surgical outcome studies. So I thought, the capsular tension ring has just really been picking up in the UK as compared to the United States, and it would be a good time for me to really dive in and come up with a population-based study outcome paper in the UK, and perhaps that will set me in good food. So I always thought to do this research, perhaps I need to go to places like London, stay in Edinburgh where I graduated, and perhaps go to Manchester Eye Infirmary. But I was thinking, maybe I don't want just do research. I want to do a bit of teaching as well, and perhaps if I could to get away with a bit of clinical skills. And I graduated from University of Edinburgh, but in the end, I've made the brave decision of coming to Dundee for my academic foundation program, simply because one of the professors I really revered, Professor Kerry McEwen, is based in Dundee, and I thought it's really close to my heart. Somewhere new, sunnier city in Scotland. So yeah, there you go. So to break down the academic foundation program, we follow through the same foundation program as anyone else. There are 6 rotations in total, but my academic block really sits in the middle of my FY2 year. And you could see that that's Margaret and me. We were really smiling and relaxing in foundation year 1, and in foundation year 2 really there was quite a big of step up for ourselves. And to be honest, I think we've got 60 months to get ourselves organized and prepared for the academic block that happens in the middle of FY2. But as you could appreciate, I think the curriculum for the academic FYs are pretty hectic, with A&E, general medicine, and surgery rotations, leaving us with very little time to really look into what we want to do, explore a bit of our academic interests, as well as attending courses that would be useful for ourselves. So none of those training we've actually received in FY1, solely because we were really too busy and caught up with clinical work. So I think effective time management is key here, and that really speaks for its own. And my aims and objectives when I came to Dundee was to really look into development, personal development in 3 aspects. I want to look into clinical governance, I want to build up a teaching and medical education portfolio, as well as establishing myself for research. And let's look at clinical governance and what I've done. So I did a close look audit on gentamicin prescribing, and I think this is something that I picked up when I started in FY1. I found out that the foundation year doctors are just too busy to remember about repeating gentamicin level. A lot of the trainees actually have very little knowledge about gentamicin prescribing, And through my study in audit cycle 1, I actually found out that the transfer of patients from acute surgical or acute medical units to downstream ward is actually a significant risk factor for gentamicin prescribing error. And following that, we actually had inclusion of gentamicin as well as the high-risk medications at handover. I spoke to Prof. Navalny, and we actually got a handover checklist tested across medical ward, and had foundation year doctors to review out of hours as to do a compulsory out of hours review on patients who are actually on gentamicin. And audit cycle 3 is actually showing that there is high compliance. So I actually presented that, and that was me putting myself in the slides. And I also did a quality improvement project with a closed loop project with Vicky Tully, and we managed to find out that because of fatigue issues, the day team to night team handover was done really well in Nine Wells Hospital, but the night team to day team wasn't done so well because some of them get really tired and people have different starting time of their shifts. So I've devised a West Block handover checklist, and I've tested that across a period of 3 months, and that was actually quite useful and is now used in West Block. When I had my rotation in geriatrics and medicine of elderly, I found out that the adult with incapacity form was just routinely filled up for every single patient who's actually confused. So I thought maybe the junior doctors are not really aware of the issue of capacity, and I thought that was a hot trend about capacity and whether or not we take consent from them, whether or not we assess them, about reversibility and stuff. So I did an audit and devised the checklist that is now hopefully still in Ward 5 and 6, and hopefully we'll be able to introduce that across wider population in Nine Wells Hospital. So that is my role in clinical governance. And as for teaching and medical education, once again, I'm a really ophthalmology geek. I design, organize, so there is this IC simulator machine that is routinely used just for these specialty trainees to train their phacoemulsification skills. And I actually, being someone who's really keen, I've been on the machine for more than 50 hours, and I thought the modules are really easy, and I think the medical students can actually do them, and if they could start really early in their career, it would set a really good record for themselves. So I devised a curriculum for microsurgical skills based on the modules that's available in the IC simulator machine, and introduce it across Tayside for foundation year doctors and senior medical students. And as you could appreciate at the small corner over here, the feedback has been overwhelmingly positive. It just shows that the foundation year doctors and senior medical students, if they put in enough time and dedication, they are not any worse than any ST1 or ST2. And if they are guided by people who are experienced in dealing with microsurgical skills, they can actually achieve similar competencies. And I presented it in the TASME conference and got awarded the Young Educators Award. I also designed, organized, and led the Duke Elders Undergraduate Prize Revision Program for 2 consecutive years, and I'm really proud to say, although University of Dundee is a relatively smaller university with less people registering for the competition, but we are the top performing medical school in Scotland and top 3 in the UK. And I also signed up to do distant learning for postgraduate certificate of medical education, and I think this is something that's really valuable for myself. Prior to entering academic foundation program, I have no knowledge about Masters of Medical Education. All I thought about medical education was just getting involved in Clinical Skills Center, doing OSCEs. But it really goes beyond just that. And I'm really glad to have signed up to this distant learning course, which allows me to really do it at my own timing across a period of 1.5 years. And I'm a proud winner of the FAME Awards. So now down to the really important bit of the reason why I came to Dundee. It is solely because I thought this is a good center to establish myself as someone who's really keen in research. So I first started in the surgical block. I've had back-to-back surgical rotation in general surgery as well as plastic surgery. So I got myself involved in doing outcome study on laparoscopic resection of colovesical fistula, which happens a lot in Crohn's disease or inflammatory bowel disease or diverticulitis. When there is inflammation of the gut, it sets a track to the bladder, and whether or not it can be resected through laparoscopic surgery, there is very little scarce evidence in literature. So we did that, and as compared to all 5 studies in the literature, we are actually performing really well. So that was really good, because now they're thinking about putting laparoscopic surgery into one of the gold standard guideline of management for colovesical fistula. And then I went back to my favorite topic, which is ophthalmology, and I really want to look at capsular tension ring. And I went to the ophthalmology department thinking that that was the thing that I was going to do for 4 months when I'm doing my academic block. But unfortunately, the capsular tension ring, as I mentioned to you, is just really picking up in the UK, and they are not doing it routinely for all patients in 9 wells. So I thought to myself, what can I do when I really want to pursue down this line of having this in my CV? So I spoke to my previous supervisors when I was doing my medical electives as a medical student, and he interestingly had a database of all patients with pseudoexfoliation who had this capsular tension ring to really keep the structure of the eye and the zonules intact, so you could have safe phacoemulsification, good cataract surgery outcome. And we did the study, which showed that, unfortunately, with capsular tension ring, although it is good for intraoperative benefits, meaning it's good for the surgeons because they are not worried that there is any complications during the surgery, but post-surgery, post-operative outcome, there is no significant difference. So there is no value in recommending capsular tension ring in preventing post-operative complications of cataract surgery in patients with weak zonules in their eyes. And then I flirted a bit with radiology, and I went to radiology department thinking that I really wanted to do cardiac CT, and I met a couple of really smart academics like Jonathan Will McCoy. I spoke with a few professors who have radiology background or cardiology background, and interestingly, as I was really deciding what I want to do for my specialty training, I came across a patient who has got aortic dissection, but look at that, it's a circumferential dissection, and I thought if it wasn't for CT scan of the heart, we would have never picked it up, and this is so interesting. So I wrote it up, and we got awarded the Image of the Month by British Society of Cardiovascular Imaging, and it was just amazing. But I decided in the end that perhaps that was not for me. And one thing to highlight is the Discovery Travel Award that's available in East of Scotland because of the population, and we've got a population of FY for 65 FYs or 80 FYs, and not many people are aware of the Discovery Travel Award for junior doctors. So I applied 2 consecutive years and managed to get £600 in return. So that was amazing. And I thought to myself, if I had ended up in Edinburgh or London, I perhaps would not have gotten so many opportunities in grant application or a bursary application. And I thought that's perfect. And throughout my time in Tayside, I've published 2 papers in Surgical Journal, and recently a paper on the capsular tension ring as well as pseudoexfoliation. And it all happens because I've got 4 months off my clinical duties to really just concentrate on my academic interests and really put in my time in writing and rewriting and address to rejection from various journals. As for why I had not have a complete set of data to present to you today is because I got really interested into so I told myself, right, I couldn't do pseudoexfoliation in Tayside because they just don't see enough patients. I couldn't do capsular tension ring because they don't implant that enough. I couldn't do ocular biometrics because my database was left in Edinburgh. So I told myself, what is the key that they are doing in Dundee? And I went back and have a think. I took a week off of my block, and I found out that it was the screening program, because Tayside has been really active in advocating for screening program. And I had a look, and one of the consultants in ophthalmology department did a study that showed a very interesting finding that children who are deprived in Tayside, they are more likely to have failed what we call a preschool visual screening. And this is a screening program really targeting at every single children. It's a whole population screening. Every single children who, before they enter school, to make sure that they can see enough, that vision is not going to be a hurdle for them to learn. And it is noble because then it shows that even though people are deprived, we need to reach out to them to screen these children because they may not have automatically present themselves with problems of the eye such as squints or strabismus and myopia. So I decided to follow up this group of children and do a longitudinal cohort study because this study was done about 3-4 years ago. So now these children would have outgrown whatever condition they have had. They would have been in 9 to 10 years old and they would have way past the golden period of time that we're thinking about for amblyopia correction. So I followed these people out and did a population cohort study. And my question is whether or not you being deprived would affect the final visual outcome, whether or not there is a difference if you are poor or if you are affluent to your final visual outcome of these children who have failed the screening test. And I really also want to look into their final binocular outcome because binocularity is very important if someone wants to pursue a career of surgery, wants to be a pilot, or wants to be a scientist. So I think that is really important to address. And whether or not a socioeconomic background is directly correlated to screening uptake or attendance rate, because right now there are papers out there saying that preschool visual screening is not value for money. You're spending a lot of money, but the uptake is very little, and there is a lot of false positive in the screening. So in England, not in Scotland, the screenings are not done routinely by the commissioning group. It's not commissioned in every part of England. And because I picked up what is really important in what is really good to do in Tayside really late. So I started my project really at the middle or two-thirds of my academic block. So I've wasted about a month thinking what I really wanted to do. And by the time I got all my findings, I had real difficulty in finding the right statistics to look at the data and to make sure that the message that I send out is not something that's being confounded, it's not something that's biased. But I'm proud to say the preliminary finding shows that there is no difference whether or not you are rich or you are poor. There is no difference in the long-term visual outcome, and there is no difference in terms of binocularity, so long you attend to a screening and you get follow-up in a clinic, because children who are more deprived are 3 times more likely to have DNA'd or not attend a clinic outpatient appointment. So there is lots of strategies that we can employ to make sure that these children gets follow-up at the clinic. We could get the GP on board, we could send nurses to their house, but we need to follow these children because they could achieve the same final visual outcome and binocularity as children who are more affluent in Tayside. Thank you.
Don't run away, people might want to ask you questions. Right, does anybody want to ask him a question? Anybody? Here we go, Rory, I'll bring you a microphone. Well, then you won't be recorded for posterity. That's good. People watch this later on.
All right, just to say, I enjoyed your presentation, and with respect to your last study that you're doing, I guess the question is whether the screening is worthwhile in the first place. So you mentioned that in England that they weren't doing this screening test. Are you planning to look to see whether screening in Scotland or in Dundee actually makes a difference in outcome rather than just affect a social class on outcome?
Absolutely. I think we've got very strong data highlighting that the screening is good for the final visual outcome. But I think that's sort of predictable in the scientific world, because if you screen people, you will be able to pick up people with visual defect and you will be able to correct them one way or another. But I think what's even more noble, that will be included in the final outcomes that I present, or write up. But I think what's even more noble is that people think one of the key reasons why it's not being commissioned in a lot of the parts in England is because they think even if they commission it, they spend hundreds of thousands to do the screening, people will not attend. There will be a low screening uptake, and that it will increase a lot of anxiety of these parents for the children. But truth be told, yes, there are many deprived areas down in England, but if we can show that the socioeconomic status has no effect at all on the final visual outcome, and that the only reason why these children are not doing well is because you don't screen them and you don't treat them, then I think it sends out a message to them that perhaps this is worth being commissioned, and we've got good evidence to show that.
Anybody else before we move on to our second speaker? Okay, that's we'll let him off the hook then. On you go. So our second speaker is Margaret White, when this works. Here we go. And she's going to give us her results and findings from that one.
I don't know. Yeah.
That one. Okay. From her time as an academic foundation doctor.
Perfect. So, thank you, Johnson, for that very dynamic and inspiring talk. I'm going to take you into a slightly different world of diabetes and focus mainly on the research that I did during my 4-month project. So, I was lucky enough to spend the 4 months of my research rotation in the McCrimmon laboratory under the supervision of Professor of Diabetes and Endocrinology, Rory McCrimmon. And it was my aim to gain some in vivo experience using mouse models, and this is the perfect laboratory in which to do it. They have numerous experts with in vivo skills. I also have an interest in diabetes and endocrinology. So to do this project, I gained my personal license on the Dundee Scott PIL course to work with animals. Okay, and I was working on a smaller part of this larger project, investigating the role of central interleukin-6 to its receptor signalling in glucose homeostasis and obesity. And why is this important? Well, we all know, as healthcare professionals, that there is a global epidemic of obesity and type 2 diabetes, and these two diseases, individually and together, are risk factors for many other diseases, such as heart disease, stroke, and cancer. In Scotland, over 65% of the population of adults over the age of 16 are obese or overweight, and this is having a huge impact on the National Health Service. So identifying and understanding the mechanisms behind obesity and type 2 diabetes could provide potential therapeutic outputs to complement a good diet and exercise. So one of the hallmarks of obesity is elevated inflammatory markers. And these inflammatory markers can interfere with insulin signaling and in insulin-sensitive tissues such as muscle, fat, liver, and the brain. Interleukin-6 is one of these inflammatory markers that has been found to be elevated in obesity. And interleukin-6 has both cell type-specific and tissue-specific effects that have been shown to be both pro-inflammatory and anti-inflammatory. And it's been shown to have an effect in skeletal muscle, fat, and liver on glucose homeostasis. But few studies have investigated the contribution of central interleukin-6 signaling in the brain. So to do this, one of the former PhD students in the McCrimmon laboratory developed a mouse model. He used Crelox technology to develop a nervous system-specific interleukin-6 receptor knockdown mouse, in which the interleukin-6 receptor expression was decreased predominantly in the hypothalamus, which is a part of the brain known to be important in regulating food intake. So mice, like humans, when fed a high-fat diet, can develop obesity and also diabetes. The researcher, previous postdoc, used 4 groups of mice, feeding a knockdown and a control group a high-fat diet, and a knockdown and a control group a normal diet. And as you can see, the high-fat diet induces weight change, but there was no significant difference between the groups. He also looked at various metabolic parameters such as food intake, glucose tolerance, insulin tolerance, and metabolic phenotyping using metabolic cages. And he found that these mice, interestingly, in both groups, whether fed the high-fat diet or the low-fat diet or the normal diet, had increased appetite, increased food intake, i.e. they were hyperphagic. And the mice on the normal knockdown diet, the mice on the normal diet that were knockdowns were actually leaner and had less fat mass. And mice in both groups, the knockdown groups on the high-fat diet and the normal diet, were less active, and they also had increased carbohydrate versus fat metabolism and less glucose-stimulated insulin secretion. So this raises many questions, but among which one of them was, if the mice are actually the same weight, but they're eating more, what is going on here? And if we limit the food intake of the knockdown mice to be the same as the control group, will they actually lose weight, and will it uncover any phenotypic differences? So my part of the project was to undertake a paired feeding study in which I was to feed the knockdown mice the same amount of food as the control group and to perform the same tests as previous. So I had two groups of mice, the interleukin-6 receptor knockdown mice and the Cree control group, which I will refer to as the knockdown group and the control group. And only female mice were available for this study, whereas the previous study had been performed on male mice. I had six mice in each group, so a total of 12 mice. They were individually housed, and we decided to feed them a standard diet as opposed to the high-fat diet, because the interesting changes we'd seen were also present on the standard chow diet. So I had a preliminary week in which I measured daily food intake and also body weight. And then I performed the phenotypic experiments, which I will explain as we go along, including echo MRI, which is a non-invasive technique of looking at body mass, glucose tolerance tests, insulin tolerance tests, and metabolic parameters measured using the CLAMS system, as well as temperature challenge. So during my preliminary week, I actually found, looking at these two groups of female mice and measuring their daily food intake, that there was no significant difference in the amount that they ate. And you can see the body weights were similar as well. And when I did the echo MRI, I found that there was no difference in the lean mass or fat mass. So from then on, we just let them eat ad libitum. So insulin tolerance can be measured by intraperitoneal injection of insulin into the mice, and then measuring the blood glucose via tail vein blood and monitoring the hypoglycemic response. And there was no significant difference between these two groups of female mice. But we hadn't seen a difference in the male mice either. And when looking at oral glucose tolerance, glucose is orally gavaged into the stomachs of the mice, and then blood glucose can be measured via the tail vein prick, and blood can also be collected for measurement of insulin secretion. And these two groups of mice had very similar levels of response to the glucose, with both blood glucose response, hypoglycemia induced, and insulin induced. So the metabolic data can be collected using the CLAMS, which is a comprehensive lab animal monitoring system, which collects measurements of metabolic parameters, including oxygen consumption, CO2 production, respiratory exchange ratio, and locomotor activity. Now, mice are more active during the dark phase, 12-hour cycle, than the light phase, i.e. our night and our day. And we'd expect their ambulatory activity to go up or be more in the dark phase than the light phase, which you can see it is. But there was no significant difference between the knockdowns or the control groups in their activity. However, in the male mice, we'd seen that they were less active in the knockdown group. Respiratory exchange ratio is one way of looking at metabolism. The higher respiratory exchange ratio normally relates to carbohydrate metabolism, and during the active dark phase, carbohydrate metabolism is predominant. In the light phase, there is a switch to predominantly fat metabolism, as in the fasting stage. However, you can see there was no difference overall in metabolism between the two groups. And one of the last things we did was look at temperature challenge. So this is another parameter that's often looked at when investigating metabolism. And these mice were kept at 10 degrees for 24 hours, and their body temperature was measured via a rectal probe. So there was no significant difference in the ability to tolerate cold between the knockdown and the control mice. So this project turned up some unexpected conclusions. I didn't see any difference between these two groups of knockdown and the control mice, but this was a female population, and the previous studies had been performed in a male population. So I think it outlines that there are perhaps gender-specific differences in central interleukin-6 receptor signaling, and previous gender-specific differences have been seen in other mouse models. It's thought to be potentially due to the influence of sex hormones and the estrogen cycle. And in fact, estrogen has an inhibitory effect on interleukin-6 production. When I measured interleukin-6 serum levels, I found that they had a similar level in the knockdown females compared to the control females. However, the previous measurements in the male mice had shown that serum IL-6 was actually increased in the knockdown males on the normal diet compared to the control diet, and this was to a similar level of both the mice for the high-fat diet. So, as with research, often one question opens up many more questions, and I believe the McCrimmon Laboratory is still pursuing some of these questions. But I'd like to say thank you very much to Professor Rory McCrimmon, Alison and Jen, who helped with the in vivo studies, and everything was done under their supervision and guidance. And for the bench work, Jamie and Susan. I didn't talk about my bench work here, but thank you. So I'm very grateful to the Academic Foundation Programme for giving me these very 4 valuable months of research experience in which I was able to gain new techniques, be part of a laboratory group, and gain in-depth knowledge of a topic. I was also able to attend Diabetes UK Professional Conference. And for future AFPs, I don't know if there are any here, but it's a very valuable time in which you plan your time, so take advantage of it. Attend clinics, teaching, and any clinical skills sessions or courses that you want to. Okay, thank you. Thank you.